So there are three main phases of the uterine cycle. And the first is menses. And menses is menstruation. It is the degeneration of the functional zone of the endometrium. When those spiral arteries that we talked about in the last video begin to spasm and constrict, they reduce flow of blood to the endometrium. That tissue begins to degrade and die, and then it sloughs off. And then, again, from 1 to 7 days, give or take, you begin to lose that tissue along with a fair amount of blood that comes with it. And this is what the endometrium looks like during or at the end of menses, right? So you essentially have lost all of this tissue. The next phase is the proliferative phase. And the proliferative phase is where you begin to rebuild that functional zone of the endometrium. And you rebuild it from the basal zone. So the basal zone is always there, doesn't slough off during menstruation, and those cells begin to multiply via mitosis and spread, thereby restoring the epithelium. And this is stimulated by estrogen. And we'll talk about this a little bit more in a few moments, but estrogen is mostly produced by those ovarian follicles. And as those ovarian follicles grow through the ovarian cycle, they produce more and more estrogen, and that's going to stimulate this proliferative phase to rebuild the functional zone of the endometrium. And this is what that looks like. So if we compare that to at the end of menses, right, where we don't have that functional zone, now we have lots of tiny new cells with nuclei that have built up this new functional zone. The third phase is the secretory phase. And this is stimulated by progesterone and a little bit of estrogen from the corpus luteum. And here, you're not necessarily building the functional zone through mitosis like you were in the proliferative phase, but you are thickening up those cells and filling these gaps between cells with glycoproteins and all these nutritious secretions so that you're ready to support the conceptus if it implants. So this is what that looks like. And you can see all this extra nutritious, delicious fluid in here. So again, we'll compare this to menses, proliferative phase, and then our secretory phase. And at this point, you are ready for an implantation event. We've discussed the internal reproductive anatomy of the female, talking about the ovaries and the uterus in a lot of detail. Let's discuss now the vagina on out to the external genitalia. So the vagina is still internal. It's a tube that extends into the vestibule. And it looks like this, right? This is that tube. And again, this is going to be where sperm comes in. It's also going to be where the baby and also the menstrual fluids come out. You can see the bottom of the uterus here, the cervix, and the external os here. These gaps around the outside of the cervix are called the fornix. And you can see rugae, these folds or rugae here in the vaginal canal that allow it to stretch, which is going to be especially important during labor. And as you get to the outside here, and now we are external, this space just outside the vagina where the entrance is called the vestibule, and it's enclosed by your labia minora. And you can see next to the labia minora, there are these glands called greater vestibular glands, and these are the glands that produce the lubricating fluid that you'll find during sex. Now, from an external view, you can again see the vestibule here, and this is the entrance to the vagina, and just anterior to that is going to be the entrance to the, or exit from, I should say, the urethra. And this vestibule is enclosed by the labia minora, which do have some erectile tissue. And at the very front of this, where the labia minora sort of flow into the prepuce, which is the clitoral hood around the clitoris there. This prepuce, so a lot of these structures in the female are homologous to structures on males. So the glans penis, or the head of the penis, is going to be homologous or come from the same tissue as the clitoris did, right? And those are both erectile tissue with lots of nerves. The clitoral hood, or the prepuce, is going to come from the same tissue that the prepuce did in the male, which is the foreskin of the male. The labia minora is going to come from the same tissue as sort of the base of the penis. And the labia majora, which encloses this stuff from the outside, is going to come from the same tissue as the scrotum of the male. And then obviously, like the ovaries are going to come from the same tissue as the testes. You can also see up here, we've got sort of a mound of fatty tissue where the pubic hair grows. That's called the mons pubis. The other external structure on females that has to do with reproduction is going to be the mammary glands within the breasts. And you can see these, they're on top of the pectoralis major, but there's this extra fat pad here, which is what sort of gives breasts their shape and size. And then within that, you have several different lobes, each of which have these secretory alveoli. These are full of secretory cells that produce milk. And that milk will go through these lactiferous ducts and out into and around the nipple. So the nipple and the areola there. And these have secretory cells and smooth muscle that can squeeze that milk out. We will talk more about lactation, or the process of making milk and then delivering it to the outside to the baby, in the next chapter. But we'll move on and talk a little bit more about these cycles. So the ovarian and uterine cycles really do go together. It's just the ovarian cycle, you're looking at it from the ovaries perspective, right? The follicle growth and things like that, ovulation. And the uterine cycle, you're looking at it from the uterus's perspective, right? The growth of the endometrium and menses. And it all starts with gonadotropin releasing hormone. And because you guys are experts on the endocrine system from chapter 16, you know that because this has releasing hormone in the name, it is produced by the hypothalamus. And it targets the anterior pituitary. And gonadotropin releasing hormone will cause the anterior pituitary to release its gonadotropins. Gonadotropins are just hormones that target the gonads. That's what the tropin means. And there are two gonadotropins in this case. One is FSH, or follicle-stimulating hormone. One is LH, or luteinizing hormone. These are the same hormones that you would see in males, but they're going to do slightly different things. And it makes a little bit more sense in females because the names are taken from their function in female reproductive physiology. This FSH is going to stimulate the follicular phase of the ovarian cycle, meaning the phase in which the follicles are growing and getting bigger and becoming important in terms of what's going on around them. Because not only are they nutritionally supporting the growing oocyte, right, that's going through meiosis, but they are also secreting estrogens. Estradiol in particular is kind of the main form of estrogen that we'll talk about. And as they're doing that, they are going to stimulate part of the uterine cycle to go forward, specifically that proliferative phase where you're undergoing mitosis in the endometrium to rebuild that functional zone. So as those follicles get bigger and bigger and bigger, you are secreting more and more and more and more estrogen. And eventually, when you hit a certain level of estrogen, that's going to stimulate release of luteinizing hormone. Now, GnRH has already caused you to make LH. But LH is going to be released in a surge at about day 14 of this cycle, and luteinizing hormone stimulates ovulation. So the egg is actually going to rupture out of the ovary, and then what's left of the follicle is going to become something called the corpus luteum, and that's why it's called the luteal phase. The corpus luteum is going to secrete mostly progesterone. And progesterone, as the name implies, helps with gestation. It is pro-gestation. And as that level increases, that causes the last phase of the uterine cycle to kick in, the secretory phase, where you fill up all those cells and the spaces between them with that nutritional goo. Eventually, the corpus luteum, if there is no fertilization, will begin to break down into something called the corpus albicans, and therefore your progesterone levels will crater, and that will cause menses, the next phase in the uterine cycle, where the spiral arteries will spasm, and you will lose blood flow, and you will begin to lose that tissue. This, at first glance, appears to be a very confusing figure, but I think it's fantastic because it shows you what's going on in terms of your uterine cycle, and your ovarian cycle in terms of your hormone levels, both gonadotropic and ovarian hormones, all at the same time. So as your GnRH, right, begins to spike, it will cause your FSH levels to spike here. And FSH causes your follicles to grow. Right? And as your follicles grow, they produce estrogen. So your estrogen levels begin to spike until eventually your estrogen levels get to such a point that they cause you to shoot out a bunch of luteinizing hormone. Right? And luteinizing hormone is going to cause ovulation and the transformation of this follicle into a corpus luteum, hence the term luteinizing hormone. Well, then we don't have this follicle anymore. Estrogen levels are going to drop significantly. Your corpus luteum is going to produce some estrogen, but mostly progesterone, and so progesterone levels skyrocket. Now, as this estrogen went up, not only did it cause eventually luteinizing hormone to be secreted, but it also caused the proliferative phase of this, the functional layer of the endometrium to occur, right, where we go through mitosis and rebuild this. And the progesterone that's here in the luteal phase is going to cause the secretory phase to kick in, where we fill this with lots of good nutrition. Now, if there is a conceptus, if a fertilization event occurs, it will secrete a hormone that will cause the corpus luteum to stick around. But if that doesn't happen, then your corpus luteum is going to break down into a corpus albicans, your progesterone levels are going to drop, and that means you are going to move over into menses, right? Now, as that's happening, you're going to secrete more GnRH, which is going to cause your FSH levels to begin to go up, right? Which is going to cause new follicles to grow, which is going to cause more estrogen to be secreted, which is going to cause this proliferative phase and ultimately ovulation of another egg and a new luteal phase, etc., etc., etc. Now, you may also notice that temperature goes up significantly right after ovulation. Sometimes people who are working really hard to get pregnant or working very hard not to get pregnant will pay attention to the basal body temperature to have some idea of when, along with the calendar, obviously, the woman may be ovulating and fertile. Because there are a lot of steps involved in the reproductive system, there are a lot of places where you can keep it from happening if you would like, and we call those contraception. And simplest are barrier methods, right? Things like the male condom. You can also have female condoms or diaphragm that's a cervical cap. But very often you'll use hormonal contraception. Generally that's in the form of a pill or a shot or a NuvaRing or something like that. Those things tend to be very low levels of progesterone or estrogen or both. And that prevents the release of GnRH. And so that prevents you from going through this cycle, at least for a while. Depending on what you're using, you might stop for a couple days or a few days each month to undergo a normal period. If you want it to be a little bit more permanent, you can do things like a vasectomy, where you essentially snip the vas deferens, or you can do a tubal ligation, which is where you essentially snip the uterine tube. Now, the vasectomy is more common because it's just easier to get to. It's a less invasive surgery because it's sitting outside the body. Those who would prefer not to, mess with their hormones can also sort of use things like the calendar and temperature and estimate when you're going to be ovulating and do what's sometimes called the rhythm method or natural family planning. And that's sort of as effective as you are willing to make it. Now, I very briefly want to talk about what can go wrong in the reproductive system. So in males, very often that has to do with the prostate. And very often in older men, the prostate will just grow. Not necessarily cancerous, but it will grow. That can cause pain. It can constrict around the urethra, make urination difficult. Sometimes, though, the prostate growth is cancerous. And this is, again, very, very common in especially older men. In younger men, testicular cancer is more common, and it can be pretty deadly if you don't catch it early, but catching it early is easier than some cancers in females that we'll talk about because, again, they're external. In women, you can get masses, either benign or malignant, on the breast, and breast cancer is one of the leading causes of death in women. We've gotten pretty good at catching breast cancer early and treating it, but ovarian cancer ends up being more often deadly because of the nature of it being internal. It's a lot harder to catch early, and that makes it tougher to treat cancers. most common cancer in younger women is cervical cancer, which is usually caused by HPV.